presenter is Dr. Anirudh Pathirban.
My PPT is not online.
Sorry?
My PowerPoint is not here.
Did you upload your presentation?
Yeah, I did.
Did you upload it here?
I didn't get any information.
Okay, so you upload your presentation. Meanwhile, we can start the next talk. Dr. Neha Kumari.
Good morning, everybody. I'm Dr. Neha Kumari from DMCH. I'm here to present on the topic of a clinical case series, visual outcome after intravenous dexamethasone therapy for idiopathic optic neuritis in Indian population. There is no financial interest involved. Optic neuritis or the primary inflammation of the optic nerve is referred to as papillitis when the optic disc is swollen and the retrobulbar neuritis when the disc appears normal. The most common form of optic neuritis is acute demyelinating optic neuritis. Optic neuritis is clinically categorized by sudden diminution of vision with associated pain on ocular movement. Although more than 75% of patients make an excellent spontaneous recovery to visual acuity of 6/9 or better, some have long-lasting residual visual deficit. The majority of patients who developed optic neuritis are between the age of 20 and 50 years. Women are affected more commonly than men. We conducted an observational study of patients with optic neuritis. Patient treated with intravenous dexamethasone, 50 mg in 150 ml of 5% dextrose over 1 to 2 hours daily for 3 consecutive days, followed by 1 mg per kg body weight for 11 days, and completed at least 1 year follow-up. Parameters assessed include visual acuity, color vision, contrast sensitivity, and RAPD. All the 10 patients were assessed for all visual function parameters. Investigation done included all the baseline investigations, CBC, ESR, CRP, and serum electrolyte, and the MRI, BEP, EEG, and VLCFA. A result improvement in the visual acuity was noted 24 hours after first dose. Near vision, color vision showed significant improvement 24 hours after the third dose. What we concluded was that treatment with 50 mg intravenous pulse dexamethasone leads to rapid recovery of vision in acute optic neuritis without any serious side effect. Now these slides showed the follow-up at presentation and day 1, day 3, and day 15. Case 1, 32 years male who presented with a best corrected visual acuity of hand movement improved to 636 on 15th day, and case 2 that showed presented with finger count 2 meter improved to 6/18, and case 3 that showed with no perception of light that improved to 6/12. Case 4 presented with finger count 1 meter that improved to 6/6, and case 5 that presented with 6/36 improved to 6/6, and case 6 44 years male presented with finger count 4 meter that improved to 6/12. There was considerable improvement in the color vision, and the case 7 28 years female presented with finger count 4 meter that improved to 6/18 on day 15, and case 8 30 years female who presented with no perception of light improved to 6/18, and case 9 38 years female who presented with finger count 3 meters showed an improvement to 6/9, and case that presented with 660 showed an improvement to 6/6. The point of discussion here is currently the ONTT trial is a standard trial, but what we were using 10% dexamethasone due to cumbersome procedure of ONTT trial. We tried with 50 mg dexamethasone that showed considerable improvement also.
Yeah, thank you, Dr. Neha. Your time is up. So, requesting all the speakers to please adhere to the timings, please. Yeah, thank you. So, the next presenter is Dr. Sai Chandana Verma. Dr. Sai is here. Okay, meanwhile, can we have the next speaker, Dr. Joe Phillips? Dr. Phillips, is he here? Is Dr. Komal Bhale here? Sai Chandana. You can start, Dr. Komal.
Good afternoon, everyone. Myself, Dr. Komal. I am final year postgraduate from Madurai Medical College. My case is a rare case of ankyloblephron filiforme adnatum. A 6-month-old child was brought by mother with the complaints of inadequate separation of eyelids in left eye since birth. Antenatal period was uneventful. There was no history of radiation exposure or any chronic drug intake in the mother. Mother was second gravida and the sibling of the child was 2-year-old healthy male child with no congenital anomalies. Birth history. Child was born by full-term normal vaginal delivery and cried at birth. There was no history of ICU stay. General examination. Baby was alert and active. Vitals were stable. There was history of cleft lip and cleft palate since birth, and no other congenital anomaly was detected on systemic examination. This image shows cleft lip and cleft palate in baby along with left eye ankyloblephron. Ocular examination, child was fixing and following light. On anterior segment examination, the left eye there was adhesion due to skin tags noted between upper and lower eyelid at the lid margins on lateral side. Conjunctiva was normal, cornea was clear, iris color and pattern were normal, pupil both eyes reacting to direct and consensual light reflex, lens was clear, right eye lids were normal, conjunctiva and cornea were normal, iris color pattern normal, pupil was reacting to direct and consensual light reflex and lens was clear. This image shows left eye adhesion between upper and lower lid noted due to skin tags by on manual separation of the eyelids. On dilated fundus examination, both eyes media was clear, disc size, shape, color and margins were normal, cup disc ratio was 0.3:1, vessels were normal, AV ratio 2:3 and macula was normal. The diagnosis of ankyloblephron filiforme adnatum was made based on the clinical findings. Thank you.
Okay, thank you. So, do we have Dr. Sai Chandana? You can start, Dr. Sai.
Good morning, everyone. Today, my poster topic is about a case report of DeMossier syndrome. Coming to introduction, it is also called as septo-optic dysplasia, which was coined by DeMossier in 1956. It is a heterogeneous group of disorders comprising any combination of optic nerve hyperplasia, pituitary gland hyperplasia, and midline abnormalities of brain, such as absence or dysgenesis of septum pellucidum. This disorder is associated with brain abnormalities in 75 to 90% of cases, and bilateral optic nerve hyperplasia, which is occurring in about 70% of affected population. Coming to case history, a 3-year-old female child came to ophthalmology OPD at Regional Eye Hospital, Kannur, presented with history of difficulty in fixating of both eyes. On examination, patient had horizontal nystagmus with no fixing and following of light. The pupillary reactions and anterior segment examination were normal in both eyes. Fundus examination in both eyes revealed pale and small optic disc with double ring sign, which is suggestive of optic nerve hyperplasia. This is the picture of fundus of both eyes showing pale and small optic disc with double ring sign. Coming to the MRI brain, it showed the impression of corpus callosal dysgenesis and absent superior portion of interventricular septum and smaller hypoplastic pituitary gland, and there is severe reduction in caliber of both optic nerves with severe thinning of optic chiasma, which is suggestive of optic nerve hyperplasia. This is the picture of MRI scan showing small and hypoplastic pituitary gland and corpus callosal dysgenesis and thinning of optic nerves and optic chiasma. Based on examination and investigation, diagnosis of DeMossier syndrome was made. Coming to treatment and follow-up, there is no definitive treatment for this syndrome as multiple associated malformations may be present. A multidisciplinary approach of radiologist, endocrinologist and neurologist and pediatrician should be done. Coming to discussion, it is one of the causes of childhood blindness. Etiology, it is multifactorial with environmental factors and key developmental genes of HESX1, SOX2 and SOX3. Optic nerve hypoplasia, it is characterized by small optic disc, which is maybe result of excessive apoptosis of retinal ganglion cells during visual pathway development. Visual acuity ranges from no light perception to normal vision. It may be associated with nystagmus, strabismus, axial myopia and astigmatism. Coming to conclusion, an early diagnosis through detailed history, physical examination and most importantly neurological and hormonal evaluation is of great importance in management of symptoms of the patient, which would impact his quality of life. A multidisciplinary approach is of paramount importance as this disorder can present with complex picture with indefinite prognosis. Thank you.
Thank you, Dr. Sai. That was a wonderful presentation. So our next speaker is Dr. Anirudh Pathirban. Is he here? Dr. Anirudh. Do we have Dr. Jofi Phillips? Dr. Phillips, right? Yeah, so the next presenter is Dr. Jofi Phillips.
Good afternoon. Shifting paradigms in the management of traumatic optic neuropathy. Traumatic optic neuropathy is a serious vision-threatening entity that may occur after head injury or ocular trauma. Direct traumatic optic neuropathy occurs due to optic nerve laceration from bony fragments or anatomical disruption, and hence it's associated with severe visual loss with lower chances of recovery. Indirect TON occurs due to stress on the optic nerve from oculofacial soft tissues and facial bones. TON is a clinical diagnosis supported by a history of direct or indirect trauma, and CT is the key imaging modality for delineating optic canal fractures. Case 1, 24-year-old healthy male with alleged history of road traffic accident sustained a laceration above the right eyebrow. He complained of mild blurring of vision in the right eye. His vision in the right eye was 624 and left eye 66. On ophthalmic examination, relative efferent pupillary defect was present in the right eye. Fundus examination and imaging was unremarkable. He underwent suturing of the eyebrow laceration. He was advised intravenous methylprednisolone for 3 days, followed by oral steroids. On follow-up, vision in the right eye improved from 612 to 69. On CT orbit, there was fracture of lateral wall of right sphenoid sinus noted with hemosynus. Case 2, a thin elderly patient with head injury with alleged history of RTA was evaluated. He had been diagnosed with traumatic brain injury also and admitted. Right eye showed anisocoria and RAPD. Systemic steroids were not administered because of traumatic brain injury. His right eye vision was perception of light and left eye 6/9. Case 3 is a 27-year-old gentleman who presented 11 days after a road traffic accident. He was evaluated elsewhere and systemic steroids were not given previously. On examination, right eye vision was perception of light with RAPD. Left eye vision was 6/6. CT orbit showed fracture of the roof and posterolateral wall of the right orbit. He was administered intravenous methylprednisolone and then oral steroids. On follow-up, vision in the right eye improved to hand movements. The HD OCT showed decrease in RNFL and NRR thickness in the right eye compared to the left eye. In discussion, the International Optic Nerve Trauma Study did not yield any significant differences in visual recovery when compared to those under observation, those treated with corticosteroids and those who had surgical decompression of optic nerve. The CRASH study found increased mortality rates among patients with TON and traumatic brain injury treated with steroids. The overall incidence of TON is 7.7 to 2.5%, and the most commonest cause is trauma followed by road traffic accidents. The clinchers which help in the clinical diagnosis of TON is the incidence of ocular injury, presence of RAPD, varying degrees of loss in vision, color vision defects, and visual field defects. Neuroimaging is helpful. CT imaging with 1 mm cuts is an invaluable tool in detecting optic canal fractures, orbital wall fractures, and bony impingement. In conclusion, the role of steroids is controversial. Risk factors such as age, systemic comorbidities, traumatic brain injury should be considered before administration of systemic steroids. TON is an ophthalmic emergency. There is no consensus on definitive management, and treatment has to be individualized. With this, I conclude. Thank you.
Thank you, Dr. Phillips. The next presenter is Dr. Pranav Shekhar. Is Dr. Pranav here?
Can I start?
Yeah, you can start.
Good morning, everyone. My topic, role of brisk walking in glaucoma. Starting with the introduction, glaucoma, as you know, glaucoma is a condition with progressive optic neuropathy characterized by excavated optic disc, loss of retinal ganglion cell and axons, and corresponding vision loss. Among all the glaucoma cases, primary open-angle glaucoma is the most predominant subtype, accounting almost about 74% of all the glaucoma cases. About 57.5 million people worldwide are affected by primary open-angle glaucoma. Management of primary open-angle glaucoma mainly focuses on reducing IOP. Current treatment modality includes anti-glaucoma medications, laser surgery, microsurgery, and low vision rehabilitation. Reducing IOP by exercise acts as an adjuvant therapy is now prevalent in the in the field of glaucoma because of its low expenditure and convenience. My study was conducted in Bukhara General Hospital in the Department of Ophthalmology for a duration of 6 months, which includes all the pre-diagnosed cases of open-angle glaucoma who are under monotherapy like prostaglandin analogs. My study sample size is about 52 cases. My study aims to check the effect of aerobic exercises on intraocular pressure. The subjects were randomly divided into exercise and control group, where exercise group were characterized by 30 minutes of brisk walking for a period of 3 months with a frequency of 20 times a month, and the control group weren't advised any exercise. Other ophthalmic parameters were included like best corrected visual acuity, IOP, OCD, ONH, and perimetry. IOP was measured at the beginning and then after end of each month for about 6 months. Each IOP was performed at least 2 times, and the third time was taken only in cases of more than 2 mm of difference. Average IOP values of patients were recorded every month post-exercise. My study excludes the cases of angle closure glaucoma, post-trabeculectomy or ocular surgery, secondary glaucoma, and systemic illness restraining physical activity. My study, coming on to the results, my study includes age distribution from 30 to 70 years with maximum population of 51 to 60 years. Amongst the exercise group, compliance rate was about 85%. On calculating the odds ratio, it came out to be more than 1, which shows the strength of association for my study is good. On calculating the mean difference in the IOP amongst exercise and control group, it was found that the mean reduction of the IOP after exercise was about 2.33 mmHg. This graph is showing a difference in the IOP post P and post exercise among the exercise and control group, which showing marked difference after 3 months of exercise. Out of 52 cases of primary open-angle glaucoma, 64% of the amongst the exercise group was showing significantly positive results. According to the early manifest glaucoma trial, the risk of glaucoma reduces by 10% for every 1 mm of reduction of IOP. All these facts states well that the brisk walking could be helpful enough in the protecting the optic nerve of primary open-angle glaucoma patient, and should be encouraged amongst them. Since the duration of the study was too short, so commenting on other ophthalmic parameters is not significant. My take-home advice is to go for a regular checkup, have healthy diets, and always have regular aerobic exercise, and always take medications for anti-glaucoma. Thank you.
Yeah, thank you. So next we have Dr. Anirudh Pathir.
Good morning, ladies and gentlemen. I'm going to be presenting a case report on aniridia, ectopia lentis, and amblyopia conundrum. We present to you a 13-year-old female whose chief complaint was gradual painless loss of vision in both eyes since her early childhood. When probing onto the birth history, we found the only thing that positive was a second-degree consanguineous marriage. On general examination, we noticed that she had low set years. Both these points triggered us to look into the syndromic association spectrum. On ophthalmic examination, we found her to have horizontal nystagmus, and in the right eye we could see that the visual acuity was just 160, but not improving with glasses or pinhole, but with plus 10D it was improving to 6/60. Iris, we noted there was complete absence of the iris and iridia, and the lens was superiorly subluxated with minimal lens changes. This hold true for the left eye as well. Here in the anterior segment images, you can see that both eyes we have superiorly and anteriorly subluxated crystalline lens, and you can see the stretched out zonules. Gonioscopy of both eyes in all quadrants, we could find that the angles are open. We tried to do visual fields and color vision, but it couldn't be assessed because of the patient's poor visual acuity. Fundus was absolutely normal, except for the fact that there was mild haze due to cataractous lens, and we had an absent macular foveal reflex, hence which probed us into further imaging. In search of the fovea, we did an OCT macula, and we could find that there was no foveal anatomical orientation at all. Foveal hyperplasia was noted thus. UBM revealed zonular stretching, and you can see that there is an actual superior and subluxated lens as such in both eyes. Based on these above clinical findings, we arrived at operational diagnosis of both eye aniridia, ectopic lentis with foveal hyperplasia leading to amblyopia. Thus, we wanted to rule out all syndromic associations with it. We did a battery of investigations to rule out Vaga and Gillespie, electrocardiogram, echo, USG, abdomen, pelvis, CNS examination, and MRI brain. All of them are found to be absolutely normal. We were unlucky because we didn't have any findings, but I would say that the patient was very lucky not to have any positive findings. Treatment options, we were pondering upon whether we have to go for an anterior implant or spectacles for constant use. But since the young age of the patient and since she reported no glare, we wanted to go in for spectacles and just follow up the patient as such. I actually presented this case for its rarity. Aniridia is seen in approximately 1.8 in every 1 lakh live births. It basically occurs in 3 forms: an isolated aniridia and a systemic form, which is associated with Vaga and Gillespie. Based on our clinical findings, we found out that this case was a case of isolated aniridia without systemic involvement. Thank God for the patient. Thank you.
Thank you, Dr. Anirban. I think an aniridia IOL with a scleral fixation would have been of great help in this particular case.
Yeah, but since the child actually wanted to go home and she was not actually willing in the current setting, we actually wanted her to come back as well. We're still following her up.
Yeah, that was feasible, but I'm just telling the best option in such a case would be you take a aniridia IOL and you scleral fixate it either by MNA or a double scleral flange technique.
Thank you.
Yeah.
Thank you, sir.
Yeah, so the next speaker is Dr. Soumya. Is Dr. Soumya here?
Good morning. My topic of discussion is what the mind does not know, the eye cannot see. What does it mean? A systemic ocular evaluation can, in many instances, provide a clue to an underlying systemic disease. It is easy to overlook other aspects of vision when visual acuity is normal. This case highlights the importance of thorough clinical examination in picking up a potential life-threatening condition. A 67-year-old diabetic female with blurring of vision came to my OPD 1 week back, seen already by 2 ophthalmologists, and reassured symptoms persisted and hence came for a third opinion, required some assistance to the slit lamp. On examination, the visual acuity was 6.6, color vision was normal, anterior segment was normal, pupils were brisk, fundus were normal, and ocular movements were normal. On further evaluation, we asked several questions for her and regarding the type of visual disturbance, blurring more pronounced on the left side. Asked about any recent systemic complaints, revealed some mild imbalance while walking, which she had attributed to the age. Her visual fields by confrontation reveal left homonymous hemianopia. The fields corresponding to the left homonymous hemianopia. MRI brain was taken. An acute infarct involving the right PCA territory, and the MRI shows low signals of the distal right PCA. Further treatment, she was referred to a neurologist and treated with low molecular weight heparin since thrombolysis was not done as she presented after 1 week. So coming to the discussion part, neuro-ophthalmic manifestation of CVA include gaze palsies, field defects, reduced visual field acuity. Complete homonymous hemianopia only occur in about 8% of all strokes. Spontaneous visual field improvement may occur post-stroke in variant degree up to 50% of the cases in the first 3 to 6 months. Coming to the conclusion, detailed ocular evaluation can pick up systemic diseases, especially neurological. We need to look beyond the visual acuity to aid in reaching the right diagnosis. These are my references. Thank you.
Thank you, Dr. Soumya. That was very insightful. So, do we have Dr. Vishaka Rathod?
Rathod Vishaka. Good morning everyone. Title of my study is Effectiveness of Glaucoma Diagnosis using OCT in patients with unreliable SAP. Coming to introduction, the diagnosis of glaucoma has been traditionally relied on assessment of optic disc and testing visual fields. Standard automated perimetry is commonly used to assess the functional loss in the patients with glaucoma. SAP is more subjective and it is associated with the unreliable results. Likewise, OCT is an objective method and it is increasingly becoming a primary approach to evaluate the optic nerve head, and it leads to the early diagnosis of glaucoma. We aim to study the percentage of unreliable SAP, to analyze the socio-demographic factors of patients with unreliable SAP, to calculate the effectiveness of glaucoma diagnosis using OCT in patients with unreliable SAP. It was a descriptive cross-sectional study. The sample size was 100 and the duration was of 12 months. All the patients with primary open-angle glaucoma and all the glaucoma suspects were included into the study. Patient who did not give the consent, patient with dense cataract, leukomatous corneal opacity, aphakia, pseudophakia were excluded. We had taken a detailed history of the patient, which included locality, education, occupation, income and socio-economic status of the patient. Comprehensive ophthalmological examination was done, which included visual acuity, slit lamp examination, gonioscopy, fundoscopy. Then later structural and functional assessment was done with the help of visual fields, that is HFA 30-2, and we did the OCT analysis to look for RNFL thinning. Finally, the percentage of RNFL thinning in the unreliable SAP will be calculated and analyzed. The results showed that 60% of the patient had unreliable results in the perimetry, and most of them were females and were from the rural background, and the most of the patient in the age group of 51 to 60 showed that there was a higher rate of the unreliability in the older age group. We also found out that the most of the patient who had unreliable result were illiterate and from the lower educational background. 44% of the unreliable patients were from the upper lower class and 40% were from the lower middle class, which shows that the lower socioeconomic status also has a direct impact on the unreliable results. Most of the patients with unreliable results were farmer and housewife. Then we did the OCT on this unreliable patient. We found out that 58% of the patient apparently had RNFL thinning but were not diagnosed on the perimetry. A combined analysis on OCT showed that 51% had RNFL thinning as well as cupping of 0.6 to 0.7. A study showed that the most of the age group with unreliable SAP were in age group of 50 to 70, which correlate with the study carried by Catherine et al. To conclude, 60% of the individual in our study had unreliable results. Most of the cases with unreliable perimetry were observed in female in age group of 50 to 70, predominantly were from rural areas, were engaged in farming and homemaking, and were with the low literacy level and low socioeconomic status. Among these individuals, 58% were diagnosed having glaucoma using OCT. It highlights the critical role of OCT in diagnosing glaucoma in this group. Thank you.
Thank you, Dr. Vishaka. Very nice presentation. So our next speaker is Dr. Varsha Negi. Dr. Varsha is here. Is Dr. Varsha here? Do we have Dr. Ritika? Dr. Ritika Vani, is she here?
Good morning. My title is From Eye to Brain. Myself, Dr. Ritika Vani. Introduction: prostate cancer is the most common malignancy among men and is the second leading cause of cancer death in men. It is unusual for prostate carcinoma to metastasize to the central nervous system, making it the subject of the case report due to uncommon events of neurological side effects. Increased awareness of atypical manifestations can contribute to early intervention and help enhance outcomes. Here is a case report of 63-year-old male who presented to our hospital with chief complaints of drooping of right upper eyelid since 1 week, diplopia since 4 to 5 days, and slurred speech and blurring of vision since 4 to 5 days. He is a known case of uncontrolled diabetes mellitus on insulin treatment. There is no significant history of any ocular trauma or any surgical intervention recently. Patient has well built and adequately nourished. On examination, on inspection, patient had facial asymmetry and bilaterally raised eyebrow. On physical examination, significant physical examination revealed ptosis with MRD1 -1 and MRD2 as 4 millimeters. Asymmetric pupillary reaction was noted, but right pupil was 4 mm dilated, non-reactive to light. Bilateral and alternating exotropia was noted. Right eye was depressed and abducted with disconjugate gaze. All cranial nerves were intact apart from 7th and 12th cranial nerve. Here we can see there is tongue deviation as well as ptosis, and there is diplopia on right gaze, but worsened on left gaze. In investigations, both eye fundoscopic investigations was normal. MRI plane showed cellular lesion extending into the suprasellar cistern and right cavernous sinus engulfing the third nerve. Later during hospital stay, he complained of worsening urinary urgency, hesitancy, hematuria, and incomplete emptying. Ultrasound guided prostate biopsy was showed prostatic adenocarcinoma. CT scan abdominal and pelvis showed enlarged prostate with heterogeneous enhancement and intravascular vesicular extensions. PSA levels were found to be raised. Cellular lesion biopsy was referred as the patient did not give consent. After all the investigations, he was diagnosed with right oculomotor palsy secondary to prostatic adenocarcinoma with metastasis. Thus he was started on chemotherapy with injection docetaxel, that is a toxoid antineoplastic agent, and injections such as colony stimulating factors and bisphosphonates. After 6 months of treatment, this is the improvement showed where ptosis is improved and tongue deviation was also improved. Discussion: prostate carcinoma is the second most malignancy with range of symptoms. Metastasis is usually in bone, lymph nodes, liver, thorax, and brain. This case was interesting as the patient's initial presentation was oculomotor nerve palsy with subsequent analysis leading to primary tumor showing primary pituitary prostate adenocarcinoma. Prostate adenocarcinoma is characterized by morphological features like luminal prostate cells and prostate raised PSA levels. We present this case of patient who presented with ptosis due to clivus involvement secondary to metastasis of prostate cancer. It is important to have a broad differential diagnosis including metastasis. This is example of a multimodal approach with broad differential diagnosis.
Yeah, thank you, Dr. Ritika. Excellent presentation. Next, we have Dr. Shivani. Dr. Shivani is here.
Good morning everyone. Today I am presenting a case of drug-induced coronary angle closure glaucoma. As we all know, acute angle closure attack is an ophthalmic emergency where the delayed recognition and treatment can result in blindness. And there are several drugs which has a potential to precipitate acute angle closure attack. And they are adrenergic, cholinergic, anticholinergic, antidepressant, anticoagulants, and sulfur drugs. So clinicians should always review the medications in patients presenting with the symptoms of acute angle closure attack, such as acute onset of ocular pain, headache, blurred vision, nausea and vomiting due to raised IOP. The purpose of presenting this case report is to bring attention to the drug-induced angle closure glaucoma to all the clinicians who serve as a first contact of medical care in these patients in order to facilitate early recognition and appropriate care. Here is a 62-year-old female patient who was referred from psychiatric department with a complaints of pain, redness in left eye since 1 day. On detailed history taking, it was noted that she was undergoing treatment for depression and was started on desvenlafaxine and clonazepam BD since 2 days. On examination, the distant vision was found to be 6/24 in right eye and 6/16 left eye. On slit lamp, there was a circumcorneal congestion with corneal epithelial edema, which was more in left eye compared to right, and shallow anterior chamber noted with VH grading 2. The pupils of both eye were reactive to light and had an immature cataract. The fundus was normal in right eye, and because of hazy cornea in left eye, the details couldn't be made out. The IOP was 28 mmHg in right eye and 64 mmHg in left eye, measured on Goldman sublimation tonometry. The B scan of both eye were normal, and AIOC and gonioscopy couldn't be done as the patient was not cooperative. These clinical findings and drug history led to a strong suspicion of drug-induced acute angle closure attack. So patient was advised to withdraw desvenlafaxine immediately and was started on topical anti-glaucoma medications such as combination of dozolamide 2% and timolol 0.5% eye drops 8 hourly, oral acetozolamide tablets 250 mg TID, and 1 gram per kg body weight of 20% mannitol 12 hourly with injection of around 50 mg IM. The next day, patient was clinically and symptomatically better with reduced pain and decreased signs. The IOP was 13 and 14 mmHg in right eye and left eye respectively. The topical anti-glaucoma medications were continued for a week, and in the follow-up after 1 week, the vision was improved to 6/18 in right eye and 6/11 in left eye, and on gonioscopy, angles were found to be open with grade 3 according to Schaffer grading system. and all the anti-glaucoma medications were stopped after that. Desvenlafaxine is a selective serotonin reuptake inhibitor antidepressant which is used in the major depressive disorders. It causes pupillary block by pupil dilation, which is attributed to the significant anticholinergic and serotonic side effect of the antidepressants. Here, the pupil comes in contact with the lens and obstructs the aqueous flow from posterior chamber to anterior chamber, leading to elevation in the pressure within the posterior chamber, which further results in bowing of the peripheral iris anteriorly, opposition of peripheral iris to trabecular meshwork. Consequently, there will be aqueous cannot be drained out and IOP raises. The conclusion of this report was to bring the notice of the drugs which can cause secondary angle closure glaucoma, and the most common ones are topiramate, losartan, ciprofloxacin, paracetamol. And early intervention by discontinuing the offending agents and immediate management will be the better for the relief of the ocular complications. And patients should be informed of possible side effects while initiating the treatment and to report an ophthalmologist at the earliest. Thank you. These are my references.
Next presenter is Dr. Neela H.
Good morning everyone. I'll be presenting a case of neurofibromatosis type 1 with ocular manifestations.
Meanwhile, can we have the next speaker, Dr. Sayukta Kadam? Dr. Sayukta Kadam.
Good morning everyone. Today I am here to present a case of anti-glaucoma treatment induced toxic optic neuropathy in a case of TB spine. As we all know, tuberculosis, it is a major health global burden with significant morbidity and mortality. Out of the first line agents used for the treatment, ethambutol and isoniazid, they are notorious for causing optic neuropathy. Ethambutol induced optic neuropathy, it is a well recognized side effect and it occurs in 1 to 2% patients taking the medication. While with isoniazid, it is very rare. Only 11 cases have been diagnosed and reported so far. Hence, the diagnosis is missed and can lead to delay in treatment. The purpose was to report the case so that it will aid in better clinical evaluation, diagnosis, and management with patients having similar presentation. It was a hospital-based case report documenting all the clinical findings of the patient. Coming to the presentation, we have 75-year-old male who presented with diminution of vision in both eyes since 1 year, which was gradual in onset and progressive in nature. Past medical history revealed that he was a known case of TB spine and was on ATT. He had taken tablet ethambutol 15 mg per kg, isoniazid 5 mg per kg, rifampicin 10 mg per kg, and tablet pyrazinamide 35 mg per kg for last 16 months according to the DOTS regimen. There was no history of intake of any other medication. Also, there was no history of consumption of alcohol or tobacco. On examination, vision recorded was 618 N6 in right eye and 69 N6 in the left eye with no further improvement. There was no RAPD. Direct and consensual light reflexes were present. Ishihara color vision test showed normal response. The anterior segment and anterior chamber both were within normal limits. On posterior segment evaluation, we noticed that there was temporal optic disc pallor, which was well documented with this fundus photograph. On HVF, we noted that there was peripheral constriction in both the eyes, which was more in the left eye than the right eye. On OCT RNFL, thinning was noted in the nerve fiber layer. On OCT, GCL and IPL, there was thinning noted in both the eyes, which indicated loss of ganglion cells. On MRI, it revealed that there was microangiopathic changes in both cerebral hemisphere with diffuse cerebral atrophy and slight reduction in optic nerve caliber. A diagnosis of ATT-induced toxic optic neuropathy was made. The patient was advised to discontinue ethambutol and isoniazid and switch to alternative medicine after consultation with treating physician. The patient was also started on tablet tricobalamine OD and was asked to follow up after 1 month, but unfortunately he was lost to follow up. Ethambutol, it alters the reactive oxygen species that secondarily causes oxidative stress and influence mitochondrial transmission defect and conduction of optic nerve function. INH leads to loss of pyridoxine in urine and hence blocks the neurotransmitters. Hence, in this case, we conclude that intake of ethambutol and isoniazid could be the most probable cause, and also as a case had bilateral GCL IPL thinning on OCT, it is now implicated to be a more reliable imaging biomarker in comparison to PRNFL in cases of toxic optic neuropathy. Thank you.
Thank you. Dr. Neela, is your presentation ready? Dr. Neela is here. Do we have Dr. Varsha Bela?
Good morning, everyone. I'll be presenting on dry eyes associated with anti-glaucoma medications. I work at Prabhai Clinic, Bavanda. As we all know, meibomian gland disease is a multifactorial component, and it has many reasons. But are we causing it by the use of anti-glaucoma medications, and how is it affecting our patients? So first, in our study, we have used LipiView, which is an interferometer and uses and analyzes parameters like meibomian gland disease, lipid layer thickness, and partial blinks. It first records a 20-second video and gives us the following results. As we can see in this picture, this is meibomian glands with zero dropout, which is grade 0. This is grade 2 with 33% dropout. This is grade 3 with 33 to 67% dropout, and grade 4 we can see there are hardly any meibomian glands here. So in our study, we aim to analyze the meibomian gland dysfunction caused by anti-glaucoma medications. As we all know, in our literature we only have questionnaires, but no objective study has been performed. Study was conducted at Prabhai Clinic for 6 months. Our total sample size was 188 with 94 cases and 94 age match controls. The inclusion criteria were people on people with primary open angle glaucoma with single-use anti-glaucoma medications or triple use for more than 3 months. Exclusion criteria were those who underwent filtration surgery, and age match controls were used with exclusion criteria we kept similar for them too. So first the patient underwent LipiView followed by Sherman's test, TTA film breakup time test, and then the corneal staining by the Sika grading. So our results were that we found that the maximum number of patients were on carbonic anhydrase inhibitors, followed by prostaglandin analogs, and then beta blockers. Least used ones were cholinergic agonists. So meibomian gland dropout was seen maximum in prostaglandin analogs, alpha agonists, and beta blockers. And as we can see in this, the p-value was significant, and the dropout was seen in almost 24 patients. And in the lipid layer thickness was similar, and TBUT was most affected in carbonic and in prostaglandin inhibitors. So in our study, we had meibomian gland dropout and reduced TBUT. Though previous studies have shown only OS degrading, we have tried to evaluate using LipiView. So what I'd like to say is using a tear film analyzer would be a good investigative tool. time duration, sample size, and were a limitative factors, and where we have not differentiated between the anti-glaucoma medications with preservatives and without preservatives. In conclusion, I'd like to say that long-term usage of anti-glaucoma medication would lead to ocular surface diseases. Carbonic anhydrase inhibitors and prostaglandin analogs can cause significant tear film breakup time. And in conclusion, I'd like to say is glaucoma patients on topical anti-glaucoma medications should be assessed for MGD, considering it affects their quality of life with patients who have already compromised visual field.
Thank you, Dr. Varsha.
Thank you.
Is Dr. Smriti Pandey here?
Good morning, I am Dr. Smriti Pandey. I will be presenting outcomes of intravitreal anti-VEGF and laser photocoagulation therapy in treatable ROP cases. The aim of the study is to examine the anatomical outcomes of combined therapy of intravitreal ranibizumab and laser photocoagulation therapy in treatable ROP cases, wherein the treatable ROP cases were defined according to the ETROP, that includes Zone 1 with plus disease stages 1, 2 and 3, Zone 1 without plus disease stage 3, Zone 2 with plus disease stage 2 and 3, and aggressive retinopathy of prematurity. The screening of the neonates was done according to the Rashtriya Bal Swasthya Karyakram, that included gestation in neonates with gestational age less than 34 weeks and birth weight less than 2 kgs. Babies with gestational age 34 to 36 weeks were also screened if there were associated risk factors like prolonged oxygen therapy, prolonged hospitalization, adverse respiratory or cardiac disease profile. For the study, the medical records of 120 infants referred to the Department of Ophthalmology for retinopathy of prematurity screening over a period of 9 months were reviewed. The patients given intravitreal ranibizumab and laser photocoagulation therapy were reviewed retrospectively in terms of anatomical outcomes that were assessed based on indirect ophthalmoscopy with a 6-monthly follow-up. Under all aseptic precautions, the kids were given intravitreal ranibizumab 1 mm posterior to the limbus under topical anesthesia, followed 3 weeks later by laser photocoagulation therapy in the presence of standby anesthesiologist. The infants were followed up the next day of giving anti-VEGF injection, then weekly follow-up was done. The 3 weeks later, laser therapy was given, then weekly follow-up was continued till there was regression of retinopathy of prematurity. Thereafter, monthly follow-up was done till 6 months. This is where we screened 120 infants, out of which 42 were cases of treatable ROP. This is a tabulated form of the case distribution in terms of stage and zones of the disease. The mean gestation of the neonates was 32.5 weeks and the mean birth weight was 1.47 kgs. The primary treatment success was considered if the anatomical success was achieved with 1 dose of intravitreal ranibizumab and single laser photocoagulation therapy, which was seen in 38 of 42 babies, and that is 90.48% of the neonates. And the secondary treatment was considered when additional laser treatment was required. That was seen in 4 out of 42 babies. That comes to 9.52%. Comparing this with the ITCROP study that had primary success rate in 95.5% of the cases, but the eyes included were 22. And instead of ranibizumab, they gave intravitreal bevacizumab. And the follow-up was just for 2 weeks. The limitations of my study, it's just limited to the Indian patients. There was no long-term follow-up and FFA was not done. So to conclude, in our study, treated patients of ROP did not progress to stage 4 or 5. And ROP is the leading cause of blindness in children. With timely diagnosis and intervention and adequate follow-up, a child can still have a good visual prognosis. Thank you.
Thank you, Dr. Smriti. The next speaker is Dr. Shifali. Dr. Shifali is here.
Hello everyone. So my topic is assessment of neuro-ophthalmological findings in pediatric versus adult patients diagnosed with tubercular meningitis. It's a case series. So the objective of the study was to determine the effect of CNS tuberculosis or tuberculomeningitis on ocular structures and to check the progression of disease and start appropriate management to decrease the effect of outcomes. Tuberculosis is a disease with major burden on healthcare system in India with incidence of almost 192 is to 1 lakhs. It is caused by Mycobacterium tuberculosis and affects lungs mainly, but 15 to 20% cases are found to be extrapulmonary. It can spread to central nervous system, thereby causing CNS TB. It can affect the visual pathway, involve intracranial nerves, oculomotor system, thus giving some major neuro-ophthalmological manifestations. So our study was a case series, a comparative study, in which we took 16 total patients. 8 were pediatric patients, that is less than age 15 years, and 8 were adult patients more than 15 years. The study was conducted at FH Medical College, Agra, and it was followed up for 6 months. So the inclusion criteria, we involved all patients diagnosed with tuberculomeningitis, and we excluded all the patients with any other causes of papilledema, viral infections, other causes of meningitis, or the patients with significant cataractous changes in the lens. A meticulous history was taken from all the cases and followed through a thorough ocular examination. Observations were made on the modes of presentation, and criteria was applied for diagnosis and visual outcome in individual patients. So in material methods, the following investigations were done in all patients, that is the visual acuity by Snellin's chart, color vision, anterior segment by slit lamp biomicroscopy, extraocular movements, fundus examination, CSF examination, and CT brain. So out of the 8 pediatric patients, my first case presented with the decreased vision and deviation of the right eye, and also there was blurring of disc margins in 360 degree. Also the patient had CT findings of basal exudates. Similarly, case 5 had hydrocephalus finding in the CT brain with other findings similar, and case 8 and case 6 also. In adult patients, out of total 8 patients, case 1 presented with decreased vision and papilledema, and similar findings were found in case 4 and case 5 and case 6. So on comparison, what we found was that in the extraocular muscles, lateral rectus palsy was more commonly found in pediatric patients in comparison to the adult patients, whereas papilledema was also more commonly found in pediatric patients than adult patients. But diminution of vision was more significant in the pediatric patients. So out of 8 pediatric patients, diminution of vision was found in all the patients. 5 were severely affected with lateral rectus palsy, along with the optic disc changes on fundus examination. And adult patients, out of 8 adult patients, 4 presented with almost near normal vision at presentation, but papilledema was observed in all 4 patients that had presented to us. So our conclusion led to this, that pediatric patients mostly were affected with lateral rectus palsy and diminution of vision, whereas adult patients were most commonly affected with papilledema. Thank you.
Thank you. Dr. Meghna Dikshit, please. So the next speaker is Dr. Meghna Dikshit.
Good morning, everyone. I am presenting a case of photic retinopathy after a lightning injury in a tertiary care hospital in Uttar Pradesh. A 40-year-old male resident of Sitapur farmer by occupation presented with the complaints of redness, watering, swelling, and diminution of vision in the left eye since one day. According to the patient, he was apparently asymptomatic one day back when he developed sudden redness and watering and swelling in the left eye after lightning injury during thunderstorm while working on the fields. He also complains of diminution of vision in the same eye, which was sudden in onset and was not associated with diplopia and colored hollows. On ocular examination, in the left eye, the vision was 618 unaided, and with pinhole, it was not improving, and the near vision was N12, and the best corrected visual acuity was there was no improvement found. The eyelid, eyebrows, and eyelashes, there was periorbital swelling. In the conjunctiva, there was diffuse congestion and irregular focal areas of stain positive suggestive of corneal punctate epitheliopathy was found with epithelial edema, and the anterior chamber iris details could not be assessed. In the same finding, the pupil and lens details could not be assessed, and the IOP was digitally raised. The treatment: eye drop moxifloxacin 4 times per day, and eye drop sodium chloride 5 times per day, carboxymethyl cellulose 4 times, and timolol and bromidine 2 times were given. And the following systemic evaluation were done but were found to be within normal limit. On the first visit, which was after 1 week, there was no improvement in the vision, and corneal edema and cells and flare were also found this time with RAPD grade 1. And on fundus evaluation, mildly hazy due to corneal edema, and disc size was it was a edematous disc with irregular shape, and margins were blurred, and it was hyperemic. And therefore, we started on IV methylprednisolone 1 gram for 3 days, and tablet prednisolone 60 mg was given after that with tapering doses. Pantoprazole was started with timolol and bromidine in the left eye. But the patient was highly non-compliant, and vision was dropped to finger counting at 3 meter, with cells and flare increased, and pupil was sluggish reaction was found in the pupil. OCT macula and optic nerve head was advised, and eye drop prednisolone was added to the previous treatment, and MRI brain and orbit was also advised. And these are the OCT macula and optic nerve head pictures. On the basis of history and examination, my diagnosis was thermal papillitis with anterior uveitis due to non-contact lightning injury in the left eye. Photic retinopathy is a retinal toxicity which is most often caused by an invert exposure to external high-risk condition. Usually presents as foveal maculopathy, but in this case it presented as uveitis and papillitis, which is a rare presentation, and it requires a multidisciplinary approach with proper counseling of the people working outdoors, especially to wear proper protective eye gear. Thank you.
Thank you, Dr. Meghna. So the last speaker for today's session is Dr. Akshaya.
Good morning all. I am here to present Leber hereditary optic neuropathy, the inherited curse. A 8-year-old girl presented with complaints of defective vision in both eyes for the past 6 months. Birth and developmental history was uneventful. That was a family history of squint and older brother, and he was diagnosed as a case of mitochondrial disease, leak syndrome 1 year back. Visual acuity in both eyes were 636 improving to 618. Anterior segment was normal, and color vision was normal in both eyes. There will be a centrocecal scotoma in right eye. On fundus examination, both eye media was clear, disc hyperemic, 360 margin blurring plus, and venous tortuosity and macular foveal reflux were present. Corneal topography showed K1 reading was 41.25 diopter in both eyes, and K2 was 45 diopter in both eyes. OCT optic nerve head showed both eye optic disc elevation was present, and in an OCT RNFL, both eye RNFL thickening was noted. On further investigation, MRI brain and spine showed no abnormality. VP, that was mild P100 latency was prolonged. Anti-emoji antibodies and NMO antibodies was negative. In FFA, there was no leakage from the disc. On further genetic analysis, they revealed a homogeneous variant of uncertain significance, which is autosomal recessive Leber hereditary optic neuropathy. DNA J330 variant was revealed. Leber hereditary optic neuropathy is a rare mitochondrial disorder which typically presents in young males with progressive visual loss due to optic neuropathy. Men are more frequently symptomatic than women with an 85% male predominance. It is a mitochondrial DNA point mutation which is maternally inherited. Mutation causes degeneration of the retinal ganglion cells. It usually presents with painless progressive vision loss, centrocecal scotoma, and pseudodisc edema. The prognosis is usually very poor. Conclusion, hence genetic screening is advised in families with a history of Leber hereditary optic neuropathy to prevent profound visual loss, and differential diagnosis of LHON should be considered in any patients who presents with bilateral optic neuropathy of unknown cause. Smoking and alcohol consumption can be avoided in order to minimize mitochondrial stress, and symptomatic measures include low vision aids and antioxidant supplementations. Thank you.
Thank you, Dr. Akshaya. So that concludes our session. Over to the next session.